Yeah, so it was a very nice presentation, and for the beginners, it's very important that one should always have safety in mind whenever you're doing transeptal puncture. But once we have done a few, then your confidence grows up, and then it becomes looks like very easy. One of the things I would like to add is the point of anticoagulation. Now, it's recommended that before you enter the LA, you should be fully anticoagulated, and your ACT should be more than 250 or 300. And most of us actually fear it that if in case there is something goes wrong and you've already anticoagulated, there will be bleeding. So some kind of imaging guidance makes us more confident, and especially in few initial cases, you can do under transesophageal, or now we have availability of intracardiac echo that will help us in be sure that you are entering towards the LA. And if you're not confident enough and you're not fully anticoagulating, then at least you should give some heparin, maybe 2,500 or 3,000 before you start doing the procedure, so that no clot formation happens within the sheaths. And once you have entered, immediately you should give fully anticoagulate and then recheck your ACT, and should be above 300 during most of your procedure. You should do it periodically, maybe every 15, 20 minutes or so, and maintain your ACTs above 300. Especially
What?
important for long procedures like pulmonary vein isolation or VT ablations. It's very, very important that you keep your ACT above 300.
What is your choice for hardware, sir? The sheaths, needle, and do you still use the LA guide wire or you use 3-2 wire to enter the LA?
Yeah, so we what we do is we use the Swartz catheters, either SR0 or SL1, rather than the Mullins dilator, because it avoids one step. And but if it's going to be a long procedure, what we do is we put the LA pigtail wire, jalebi wire, what we call it, and used typically in balloon mitral valvuloplasty. And then if we need, if we expect a long procedure, we change the SR sheath to a edgeless sheath, deflectable sheath, so that that makes our procedure easy if we have to maneuver a lot within the left atrium. But we can do it with a 3-2 wire, placing it deep into the pulmonary vein and do the same thing. It's not necessary to keep use the LA wire only, but either of the two will work fine.
So regarding needles, sir, I think we have two options, the regular BRK and BRK1. What is your workhorse and when you choose BRK1? Do you use anytime or?
We use typically BRK mainly, but in case required, we can reshape it to the shape of BRK1. Apart from Brockenborough needle, there are certain other needles which are available, the RF needle. All we have not experienced using those needles, but the SafeSep needle and all those are actually shown to be superior. And but most of us in India have great experience with transeptal doing balloon mitral valvuloplasty, and so most of us are actually comfortable with Brockenborough needle. But in patients who have thick interatrial septum, sometimes it will be difficult to cross with this needle, and if you have even crossed it, it will be difficult to pass the dilator and sheath across the septum. And then use of RF needles or RF or electrocautery to dilate or puncture the septum comes in handy. And availability of these tools also is important if you're doing these cases frequently.
That was exactly a question on the chat about thick septum. I think you have answered it. How many times you have faced it, sir? Like thick septum. I think when you are properly entering through a fossa, you hardly face this. I think when you try to enter to other
Yes.
spaces, sometimes
Yes.
when you want to.
So in patients who have never had any procedure, it's not usually an issue. Very rarely we find it. But if you have to cross a patient who had an ASD surgical closure, or maybe inferior to the device, or patients who had previous transeptal punctures where there is fibrosis, then you may have a problem in that. Another thing where it may be actually useful is when you have what we call it as a floppy septum, as Dr. Narasimhan showed. Sometimes it is difficult, and because the septum is too floppy, the moment we place our guiding catheter, the dilator, it tends up towards the other wall of the left atrium, and the puncturing with the needle will be very risky. And then sometimes these kind of tools come in handy in those situations. Never encountered such problems, but one can expect this if your volume is high.
Thank you, sir. Thank you. Can we have some tips from Dr. Rohan if he's around? Dr. Rohan, no, there, sir?
Hi. Yeah, I'm
You're
here.
around?
Yeah. Yeah, I think
Welcome, sir.
welcome. Thank you for inviting me. And I think in different procedures we have different situations. For instance, now in PTMC, for instance, if you have large dilated delays and sometimes very bulging septums. Whereas for EP, most of the time we are dealing with these patients who have normal sized left atrium. And what are the risks is that you can actually push the needle too far in and you might actually pierce through the roof of the left atrium. So in those situations, very, very careful. And the LAY is very useful in those situations because then you can actually prevent these things from happening. So that's a useful thing. In our practice, while anticoagulation is very important, in our practice, we actually don't give any anticoagulation before we puncture. We do it immediately after we puncture and confirm that we are in the left atrium. This is a practice where we have for a very, very long time. We have not had any issues with thromboembolism. But then, of course, there are other centers which do it differently. Other than that, for that, I think the hardware is standard. That's what we use. We don't have the option of using things like SafeSept and the radio frequency wires that sometimes are available. But the procedure will vary from patient to patient as well. And understand the anatomy and doing a proper echocardiogram to make sure that your cavities, particularly left atrium and right atrium, are normal size, and there are nothing that is going to separate tries is very important. So that preparation for the procedure is as important as the procedure itself.
Thank you, sir. I think like in India, I think in Sri Lanka also, we don't have a lot of these RF wires and catheters are not available easily. When you face a situation of a very thick septum or anything, do you do anything special, or you have any maneuvers by which you cross the thicker septums?
Well, one thing you find that the septum is thicker towards the edges of the foramen, so therefore you can move slightly more inferior or more kind of posterior, and then that might help. But it is a difficult. Very thick septums are a difficult. That's what makes it a difficult procedure. Certainly.
Thank you, sir. It was a pleasure to hear it from you. I think Dr. Suresh is there.
Yes, I'm there. Hello, I'm there.
Yeah, sir. Please go ahead. Loud and clear.
Just wanted to make a point, like when we take the syringe for the contrast, we generally take a syringe without a lever. So when you give a N syringe without a lever, that much force is not required when you give puff. So that's one point I would like to make. And second thing, whenever we come down and when there is septal staining, we have to bring the whole sheet out and again repeat the procedure from the SVC rather than manipulating there itself. So what Dr. Narasimhan sir was telling, that whenever you see a septal staining, you have to go inferior. So when you have to go inferior, you have to repeat the full procedure from starting from the innominate vein, the same procedure, rather than manipulating there itself. And third point, what I would like to make is that if patient has a floppy septum and whenever you're trying to puncture it, the catheter is moving up, you bring out everything, make more steep curve, and then try it. Then it will be we can be able to succeed.
Yeah, thank you for your input, sir. I think there was one thing we were discussing about thicker septums. Have you ever used RF energy to go through the septum?
No. Oh, never. Most of the things I could get with the BRK only. Never use RF.
I think one thing we a lot of time do when you face a thicker septum is you may have to give a little force. Sometimes you may have to give a little force, hold the whole assembly in your hand and try to move. Only thing is in this, you have to make sure that you're not pushing it. You hold the pressure and wait. And most of the time, the septum heals and your complete assembly goes out into the left atrium. You never push across in a
Yes.
thicker septum. Because I think a lot of us, when we do eyes, we tend to see that when you tend the septum, there are times you will see septum is going as close as posterior wall, in particular in a slower, a very small left atrium. So never give a pressure to enter the septum. If you have to give a pressure, also hold on to your assembly and keep a constant pressure rather than pushing. So most of the time we'll enter through it. Next, we have Dr. Parag also. I think we will hear from him. He comes from a very high volume place, Chandigarh. So Dr. Parag, your
sir.
inputs on this.
Hi, sir. Am I audible now?
Yeah, very clear.
Yeah, okay. So first of all, I would like to congratulate about the whole program and the lecture given by Dr. Narasimhan sir. It's so beautiful to listen to him. And probably he has covered almost everything of the topic. But and there are certain things which I have encountered in last few years regarding and the certain changes in my practice which I've done is like if I'm using a BRK1, means like if I'm using an SL1 sheath, which is my favorite sheath for doing the transeptal puncture for the PVI, pulmonary vein isolation. So I use an SL1 sheath and a BRK1 needle. But if I'm using it for a left lateral pathway or a smaller LA, I'm using a SL0. Along with that, I'm using a plain BRK. And regarding the thick septum, so we recently had a dumbbell-shaped septum where there was a very small PFO or the fossa ovalis in between. So we could actually go through the that region by using a BRK1. But there is also another BRK available. I don't know whether it's available in India. It's an XS BRK, extra sharp BRK. So we have that. The Abbott should be able to make it available if required. So we should have an access to XS BRK, which is an extra sharp BRK, which is usually done in a redo cases. So if you have prior PVI, if you have a prior multiple attempts of ablation, or there has been a case where there is a artificial PTFE patch, then you can use the extra sharp BRK also for going across the septum. Another important thing is like we did an ablation on a recently a very tall 7 feet, almost like 6 feet and 6 feet and 9 inches guy. So we had all our sheaths are not designed for them. So you will not be having your sheath will exhaust actually the length of the sheath from the femoral vein will exhaust before reaching the intraatrial septum. So there are sheaths also available with the Abbott, which we can actually ask for an extra long sheaths. So in case of Marfan syndrome or a very long, tall guy, we may have to use. Apart from that, I think so. Image guided should be a standard practice for longer procedures for a pulmonary vein isolation. You're going to take multiple things across the atrial septum. You're going to have 2 punctures. But regarding the left lateral or a standard access to the left atrium, I think so. Single puncture, not more than 8 or 8.5 French puncture. I think so. Fluoroscopic guided is enough for us. Nothing more I would like to add because Dr. Karthike has also specifically stressed upon the use of ACT while doing the procedure. That's also very important because we need to keep that parameters because you never know that you're doing a subtle procedure and you end up having stroke, which is a devastating complication. So be very proactive in terms of being anticoagulation specific. That's it, I think. So. Thank you.
How much of your transeptals are image guided and how much are fluoro guided? Maybe in your center itself.
So let me tell you very frankly, all the pulmonary vein isolations are image guided. All the transcatheter mitral repairs or the TMVRs are image guided. Left atrial appendage is image guided, but not the left lateral pathways. And pediatric ones, usually you will find a PFO. So you will not be able to, you will not require anything most of the time. And pediatric, the transthoracic echo guidance is also pretty good because the visibility of the pediatric heart is very good from the transthoracic also. So we usually do it for pulmonary vein isolations and for doing complex the left-sided flutters like you are doing a perimitral flutter, or you're doing a scar VT through transeptal route. If you're not having a transaortic route, you're doing a transeptal route to the scar VT, then you should definitely have a transesophageal echo, because that gives you two benefits. Like, first of all, your the puncture becomes very clean, that you will be very confident that even if the patient is fully anticoagulated, if the patient is non-interrupted on anticoagulation, you can straight away go into the left atrium on vision that you have not done anything wrong. And then during the procedure also, you will have the constant access to seeing the pericardium in the posterior aspect. And you will be knowing that if there is any complication because of the ablation, you will know that that small amount of pericardial effusion has started accumulating. So that's very important thing. You put the tube, patient is under general anesthesia, let it remain there, and you feel confident that, okay, if anything is going to happen, you will get to know sooner. So like not more than 8 to 10% of all our procedures are image guided.
And do you have any access to any other special transeptal accessories like RF needle?
No,
Or
I once I had a very bad septum, so Bailey's needle I asked for, but Bailey's needle is not available in India. But we have used the cautery. We've used the cautery, and that can be used, and that is fair. That's fair in Indian settings. I think so. Cautery is the poor man's Bailey's needle, not the RF needle, and it gives very good access. And let me tell you very frankly, you will never know that you have actually crossed the septum if you are using a cautery. You will actually remain, if you're tenting the intratracheal septum, even if it is thick, and you have used if you have used the cautery, you will actually enter into the left atrium immediately within few like milliseconds or seconds. You're actually there in the left atrium. So you should be cautious and should always be image guided. That is what I personally feel. If you're using accessories, you should be image guided.
So can you explain a little more for our beginners, like how do you exactly do when you are at the septum? What are your settings? And there's a question on that. So what are the settings and all that by which you go?
So I haven't gone into the literature of that. So what is the standard way? Like you drop it from the, you use the same SL1 BRK1 or an SL0 BRK0, and your tip should be abutting the intratracheal septum. Sometimes you feel a bit afraid that your tip is behind into the dilator. You should not be like that. Your tip of the needle should be abutting the intratracheal septum, and then keep the cautery plate or the earthing pad below the patient properly attached. Put a 30 cut, not the coagulation, 30 cut, and just apply to the posterior aspect of the needle, and it just transmits that energy to the septum.
Thank you. I think, is there any questions in the chat box? I don't think.